Hello everyone and welcome to the Dry Eye Debate. This virtual event has been organised by the Ophthalmologist and our sponsors today are Biotissue, ESW Vision, iMed Pharma, Oyster Point Pharma, Resono Ophthalmic and Santon, and we are very grateful for their support. My name is Alexandra Jones, I'm the editor of the Ophthalmologist and I'm very pleased to welcome our absolutely outstanding panel of experts to this debate. Including Cynthia Matossian, who will be moderating today's discussion. I would just like to remind you that our panelists will be happy to answer any questions you might have at the end of the discussion. And you can submit a question at any time by clicking the Ask a Question button on your screen. And without further ado, let's get started. Cynthia, over to you.
Alexandra, thank you very, very much for the wonderful introduction. And we are so pleased, all of you out there globally who have joined this session. So what I would like to do is start and hand over to Jen Lowe to do a short introduction about where she practices and what she does, then over to Christophe and to Alice, and then back to me. Go ahead, Jen.
Thank you so much, Cynthia, and thank you to the team at the Ophthalmologist for hosting such an amazing event. As you know, my name is Jennifer Lowe, and I'm an ophthalmologist focusing on cataract surgery, refractive surgery, and dry eye disease in Miami, Florida.
And Christophe.
Hello, I'm Christophe Baudouin. I am professor of ophthalmology in an hospital, in University Hospital in Paris, which is called 1520 Hospital. I am also the director of a research team dedicated to ocular pain, neuropathic pain, and so, of course, the overlap between dry and pain is a main topic. And I've been working a lot on biomarker research. And last point, but maybe not the least, I'm also the president of the European Dry Eye Society.
Wonderful. And Alice.
Hi, I'm Alice Epitropoulos. Thank you so much for having me. I am a cataract and refractive surgeon. We also have a dry eye center of excellence. I am a assistant clinical professor at the Ohio State University in Columbus, Ohio. Looking forward to a great discussion.
And I'm so confident we're going to have a great discussion. I'll do a brief introduction about where I practice. I'm Cynthia Matossian from Matossian Eye Associates. My current area of focus is exclusively dry eye. I stopped doing refractive cataract surgery a few months ago. I practice in Pennsylvania and New Jersey, and I'm an adjunct clinical professor at Temple University in Philadelphia. So thank you, panelists, for joining us, and thank you, the team at the Ophthalmologist, and to our sponsors for sponsoring this educational event. So I'm going to get started by asking each of our panelists, how do you define dry eye disease? We know it's multifactorial, but how do you define it? We'll start with you, Christophe.
Thank you for this excellent question, because it's one of the major debates in the past. It depends on the way to understand dry, and the best is to use the definition of the dry workshop. And the new definition, because there were two dry workshops, the first and the second, multifactorial, a disease in which osmotic stress play a role, inflammation play a role, the nerves play a role. And the new definition focused on something that is interesting, maybe to point the fact that it's an imbalance or an impairment of the homeostasis. So dry is maybe not truly a disease of the tears, but a disease of the way by which the eye is protected against the environment. So this concept of loss of homeostasis could be the core definition of dry.
Wonderful. Alice or Jen, would you like to add to that comprehensive definition?
That was an excellent description, Christophe. I think, one of the common denominators is inflammation. And that, has been carried through all of the versions of the definition of dry eye disease. But Christophe, I think you did a great job describing that.
You know, it's not, I agree completely. It's inflammation and there are different triggers, and we're going to go over that and delve into that as we move forward in this discussion. Jen, how do you explain dry eye disease to your patients, especially if they are asymptomatic? I struggle with that. It's not easy to do. So how do you do it?
You're exactly correct. Because the minute you start talking about it, they can give you this look, especially when they tell you they've been tearing and then you explain that they are dry. So it does take some time and patience to explain to them exactly what dry eye disease is and how it can be so multifactorial, and how they may have symptoms and someone else may have different symptoms, and they may not actually feel dry. So first I have to get beyond the barrier of the actual name, dry eye disease, in order to explain it. And, you know, take my time, explain that it is multifactorial, that sometimes there's a disconnect between what they're feeling and what I'm seeing on exam. Sometimes they may not even feel bad, but it's more of the symptoms of transient vision loss that they come in for. So I definitely like to, you know, pull back, take a few moments to really explain it well. And once you have that ground level understanding, I think they're much more accepting of further discussions about treatment. But again, just describing how multifactorial it is and how there is this disconnect between the signs and symptoms, and even a disconnect between what maybe their friends and family experience.
Christophe, what questions do you ask your patients to elicit the response? Because clearly, if you come to us saying, I have dry eye disease, but most come to us not knowing their diagnosis. So what questions do you ask them?
It's a question that has been raised also in the past several times. Most of patients suffer. I put on the side those patients who don't suffer, and they do have a corneal impairment. It's close to neuropathic keratopathy, for example, or very severe dry where the cornea is becoming totally or more or less anesthetized. But most of the patients complain of symptoms, but the way they express the symptom may be extremely different. It may be different from one patient to another patient. Some will have complain of burning, some of discomfort, some will describe the pain, but the word pain is not so common, so we have to be aware that pain relates maybe to something a little bit different. Some patients have also the feeling of tiredness, of ocular fatigue, and so it's extremely large range of complaints. And several studies have shown that depending also on the country and the culture, it may be also different. Some patients will not take the same wording for describing exactly the same symptom. And so it may be effectively difficult. So one approach was to move from a simple description of something like seems to be very different and heterogeneous to focusing on the consequences of dry. And the consequences are related to quality of life. It's the example of the OSDI. And personally, I still use the OSDI or derives the questionnaire. So the question is based on the intensity of the symptoms, the type of symptom, the frequency of symptom, because it's not the same of having an acute symptom but time to times, or mild symptoms but continuously, and the quality of life may be impaired in the same way. And last point, the consequences. How do you feel when you are driving? How do you feel watching TV? And are your symptoms having a consequence on this activity? So probably more the consequences more than just the symptom itself.
Christophe, that was a great, great explanation. Alice, I'm going to go to you now. And yes, what do you do? How do you elicit symptoms from patients?
Yeah, so all great comments. You know, I think as Billy Trattler had described along with his colleagues in the FACO study, visual complaints such as blurred vision was actually more likely than typical symptoms discomfort or foreign body sensation. So I think that we really need to kind of pay attention to, the patient complaints, when they say that their vision is intermittently blurry, like if they're reading or, using the computer. Going back to the initial question we were asking Jen too is, patients that are asymptomatic are sometimes the most challenging patients to treat because, they don't realize they have dry eye disease. But I think that, if we show them and educate them, for example, if we show them their meibography, if we show them their abnormal tear osmolarity or inflammatory, we can educate them that this is a disease process, it's a progressive and chronic condition that can really start to affect their, visual quality. So I think that education piece is really important.
I agree completely. I think without educating our patients, they're not going to understand, and therefore they're not going to become adherent to any of the recommendations that we make. But I want to go back to something you said, Christophe, about the impact on the quality of life. Right now, of course, we're amid a pandemic, COVID-19, global, and of course, we have to wear masks. We're doing everything virtually, like this meeting. We're not together. Instead, we are in all different corners of the world. So what impact has each of you seen among your patients during COVID and the mask wearing and dry eye disease? Alice, I'll start with you.
Thank you.
Thank you, Cynthia. We know that with the aging population, the increasing use of digital devices, and the poor American diet, the prevalence of dry eye disease is increasing. But many of us feel that this pandemic is also contributing to the increase in prevalence of ocular surface disease. With exacerbation of dry eye symptoms, along with increased chalasia and external hordeola, several of us started noticing this phenomenon early during the lockdown. In fact, chalasia was actually the #1 reason for patient-initiated telehealth calls during our mandatory lockdown. And I continue to see this in my clinic. Many of my patients who have never had dry eye symptoms are now complaining, and with objective findings over the last several months. So theoretical contributing factors may include, like we had mentioned earlier, the increased digital device use with people working at home and Zooming more, the masks, which may be contributing to increased ocular inflammation, reduced tear or tear evaporation, and potential changes in the microbial flora involving the lids and the lashes and the conjunctiva, with a possible shift towards nasal, oral, and respiratory organisms. Another variable I think that might be contributing to this is the mechanics of the blink with the mask wearing, particularly of that lower lid. So there's a group of us, we're, Jen and Cynthia, we're trying to develop a study design to prove this hypothesis of a pandemic-associated phenomenon with significant increases in the prevalence of dry eye disease, chalasia, hordeola. But there are obvious challenges, in proving this hypothesis because there's so many variables. It's tough to get an accurate baseline for comparison, and even more difficult to prove in etiologists. So we've got a meeting coming up this week to talk about this. I actually looked at the diagnosis codes this year compared to this time period over the last 2 years, and the numbers are pretty impressive. I saw a 42% increase in dry eye codes and a 101% increase in chalasia and hordeola. So wow, I think
that's really impressive. Jen, have you noticed similar trend in Miami?
100%. And I love your data, Alice. That's amazing that you looked at the codes. Certainly in my perception, so many patients are coming in. I always had a very high population of chalasia for some reason in my practice and dry eye, but even more, are coming in. I agree with you that most of the telehealth initiated calls are chalasia, and patients are coming in with a sense that it's the mask. They come in always saying, I've never had a sty before, I've never felt bad before, you know, they want to be cultured. I've had several patients ask for that. And it's really distressing. I think the psychological impact of not only dry eye, but also chalasia has been undervalued. These are some of the most upset patients we have. And I agree that I'm so excited to be part of the study, Alice, because I'm fascinated to find out the results, because there's definitely a change going on. And of course, like you said, it could be a combination with the increased screen time, but definitely something is going on to increase this, and I want to know the answer.
Exactly. And Christophe, are you noticing the same trend in Paris?
Absolutely the same. In Europe, I can extend to Europe because I recently saw a very good paper that will be soon published by an Italian team that well established the role of wearing mask, and probably the airflow due to the mask is increasing the dryness of the eye. And they showed a clear difference between those people who wear mask less than 3 hours and those who wear mask more than 6 hours. So clearly the airflow plays a role, plus the maybe compression by the mask, working on the computer. So everything is there to increase the rate of dry or to aggravate dry, which is also a condition we are clearly observing.
Actually, I just published a study on the impact of CPAP devices, you know, and prevalence of dry eye disease. And there is a little bit of air that always escapes the seal of the mask. And there's definitely a significant correlation between CPAP users and dry eye disease. So I'm wondering, just like you mentioned, all of you mentioned, there is a mechanical airflow that is almost like being in front of a fan all day as you're exhaling. So the stream of air that's being forced up past the nasal bridge and kind of impacting the ocular surface, plus all the other factors that we all mentioned. So we're eager to get the results. So Christophe, if you want to participate in the study, you're welcome.
Thank you.
Yeah, there is to go back on the airflow issue, Cynthia, there definitely is one, because have you ever put a breath mint in your mouth when you have the mask on? It completely burns your eyes. Yeah, so there's definitely proof there.
Absolutely, that's a good way of doing it. So Cynthia, go ahead.
So, just a short point. From an experimental point of view, airflow, continuous airflow on animals is a very good way to induce dry.
Yes, that's right. Some of the models actually use that. That's right. So we're all talking about dry eye disease, but we never ask the question, why is it important to diagnose and treat ocular surface disease and dry eye disease? What are the consequences of not doing it? Why are we focusing on it? We'll start with you, Jen.
Thank you. Well, it is one of the most common complaints, common reasons for ER visits even to an eye care professional. And as we know from multiple studies, without treating dry eye, we're not helping our patients get the best visual results they want, whether it be from glasses, contacts, and even surgery, cataract surgery, refractive surgery. We know that these are hinged critically on the health and stability of the ocular surface, as demonstrated by studies such as from Bill Trattler and also Priya Gupta. So we know that what we're trying to achieve as ophthalmologists is to help our patients see better. We have to treat the underlying root cause of one of the most common reasons for blurred vision. Also, I really like to look at it as a lifetime care for the eye. I have many patients come in, you know, for a routine eye exam, and they say, oh, what vitamins can I take, or what should I be doing to take care of my eyes? And I used to always think about things more related to the retina and other things, but then I realized the easiest thing to do is take care of your ocular surface. And much like we've talked about this all in the past, much like the dentists have done a phenomenal job educating the entire world on the concept of dental and gum hygiene from birth, I really feel it is one of my purposes in life to educate my patients and the public about this, because as we all see our elderly patients, they have terrible gland disease, terrible ocular surface disease, and we know it didn't happen overnight. So we really, in order to care for our patients for their lifetime, we have to start treating this.
And Christophe, what would you add, Jen? That was fantastic, to Jen's comments about the importance of diagnosing and treating dry eye disease. And then Alice will come to you.
Of course, complaint of patient, the quality of life, it's the main reason why the patient come to us. But as Jennifer told, the vision is also very important. The quality of vision is impaired in dry, which means that after cataract, after using multifocal or EDOF IOL, if the quality of the tear film is bad, then the quality of the vision and the result will be poor. And in refractive surgery also, the quality of vision will be impaired. And we know that the most important or frequent complaint of patient of failure of failure feeling by the patient after refractive surgery is dry. So symptoms on the pain, discomfort side and on the vision side are very important. And just one point, because of course when the patient is complaining, we diagnose more or less an ocular surface problem. But I have also seen many people with MGD, more or less severe, but sometimes very severe MGD, not complaining a lot, or even not complaining at all. But those patients are at risk of developing a dry eye after cataract surgery, for example, and they may complain a lot after, and it's important to diagnose before.
Very, very important point to make the diagnosis of dry eye disease ahead of time, ahead of surgery, pre-treat, and then go ahead and do their surgery. Alice, would you like to comment on that?
Sure.
Or any on this topic?
Yes, so I think Jen and Christophe really nicely described this. I think there are three compelling reasons why this is so important. As Jen and Christophe had described, we know that the tear film is the most important refracting surface of the eye. So an unstable tear film can result in inaccurate biometry and keratometry readings, which can result in suboptimal refractive outcomes. And Cynthia and I actually published this in the JCRS in 2015. And all the technologies that we have available today, the advanced, femtosecond laser, wavefront aberrometry, premium lenses, toric lenses, all these technologies have higher failure rates in patients with compromised ocular surface. Second, cataract surgery is likely to induce or exacerbate pre-existing dry eye disease in a large percentage of patients. So when surgery doesn't live up to expectations, patients are more likely to blame their surgeon before they blame their pre-existing dry eye disease. So it's really critical to diagnose this and treat prior to surgery. And then lastly, treating lid disease and blepharitis and eliminating the bacterial overgrowth helps to reduce the risk of endophthalmitis postoperatively. So again, we know that if left untreated, dry eye disease can not only have an impact on vision and comfort, but also long-term ocular health and surgical outcomes.
And these are all really, really important points. So what I tell my patients is that they have two issues going on. One is a cataract. Once removed, they'll never grow another one. And the other one is one that is lifelong and chronic and progressive, which is their dry eye MGD disease, for which they have to participate in taking care of their disease forever. And I always use words like forever. There is no cure. We have to treat it so that they kind of understand two things are going on. Cataract is once and done. Their MGD is a lifelong issue. So with that said, how does each of you work up your dry eye patient? Christophe, we'll start with you. What are the tests that you do in the office, and who does these tests? Do you do them, or do you task them to a technician?
I have effectively technician to help me. I work and I am the chairman of a referral center, which means that we have almost everything that is available from a technological point of view. I would say that if I look at the technology, the most appropriate tool is confocal microscopy. Definitively, I've been working on that, on confocal microscopy for almost 20 years, and it's a way to address the question of inflammation of the nerves, of squamous metaplasia, so of basement membrane dystrophy. So we have plenty of information, but it's not available in every center. So I have the use when I do some education program to explain the clinician that sometimes just one single drop of fluorescein is extremely efficient in taking a lot of information about the cornea, the conjunctiva, the tear film, the stability of the tear film, the way by which the instability occurs. So at the end, I need for severe patients, because my patients are mostly severe, the clinician is very important, and the clinical point of view seems to me very important. But of course, because probably there is a bias, because probably my patients are more severe and are referred for because they have not standard dry.
Alice, what tests do you do besides some of the things that Christophe mentioned? For example, we don't have access to a confocal microscopy in our office, but you're fortunate, Christophe, that you do. Of course, we have fluorescein. That's a good thing. We have lissamine green. Alice, what tests do you use? And then I'll come to you, Jen.
You know, if patients are symptomatic, I empower my technicians to proceed with point of care testing prior to me seeing them. And this really helps to make the diagnosis and it kind of improves the workflow. So my techs obtain inflammatory, which kind of detects MMP9, which is an inflammatory marker that's elevated in tears with dry eye, in patients with dry eye disease. We also obtain tear osmolarity to kind of help determine the severity and also determine the therapeutic response. And then Meibography has been a game changer, you know, when it comes to diagnosing, treating, and educating patients about MGD. I think it's an important screening tool, considering 86% of all dry eye patients have evaporative dry eye disease. So it really helps us to identify patients with this disease before there's irreversible damage. It's also a great opportunity to educate patients and guide the discussion about the disease. And then lastly, I've done this just recently. I've trained my technicians to evaluate tear breakup time and any keratitis. I used to do that, but we're trying to improve the flow and efficiency and trying to minimize the amount of time that patients are in the office. So I've kind of taught them how to do that, document that, and then that way they can check a pressure, dilate if they need to be dilated.
That's great. Really, really good points. Jen, do you do anything in addition or differently? I'm curious, as a means of working up your dry eye patients.
Thank you. Well, we like to always, of course, take a great history, and we will often use one of the questionnaires, such as the SPEED or the OSDI questionnaire, as the patients are filling in their check-in forms. One thing, and I agree with everything that has been said by Alice and Christophe, of course, I do not have confocal or inflammatory, but of course I do have fluorescein, luckily. I prefer to use fluorescein strips as a side note, because I do think it helps elucidate more of any type of staining, SPK, and helps better evaluate tear breakup time. I do use Meibography when needed to evaluate the glands, because I do also agree that it's a critical component of dry eye disease. And one extra thing I like to do even before I get to Meibography, when I'm examining the patient, after I've placed the fluorescein and done my evaluation of the cornea and conjunctiva, I like to take a moment and really focus on the lids and lashes. This is something everyone can do. Everyone has a slit lamp. takes just an extra second or two, but to look at the lashes, look at blepharitis, collarettes, think about possible Demodex. And then also I look specifically at the Meibomian gland orifices. And I'll take a cotton tip applicator and gently press on the lid margin. And you'll be surprised what you can get, what you can see. You can see if the meibum is clear and flowing, but oftentimes, unfortunately now, we're seeing more of a capped gland and even more of like a thick toothpaste type oil secretion coming from the glands. And I like to do this in patients. I think it yields a lot of information and really can guide you down the correct path.
Excellent, excellent comments. We do something very similar as well. We have cut down our questionnaire. We don't go through the formal OSDI or the speed in order to minimize the throughput of the patient and the amount of time they spend in the office. So we've narrowed it down to 3 questions. And my technicians are empowered to ask these questions. One is, do your eyes feel tired? Number 2 is, does your vision change throughout the day? We used to use the word fluctuate. Does your vision fluctuate throughout the day? And then we realized that some patients don't know what that word means, and they were embarrassed to say they didn't know it, so they would not answer or say no. So now we changed it to, does your vision change throughout the day? And something simple like that made a big difference. And the last thing is, how many times a day do you use artificial tears? Not do you use tears, but how many times a day? Because somebody who says, I use tears once a week is very different than somebody who says, I use my tears 8 or 9 times a day. So those are the 3 questions my technicians ask. And then very similar in protocol to you, Alice, we do MMP9 testing, we do meibography, and we do tear osmolarity. And then I see the patients after these tests are done, so I have this data to look at. And I use always lissamine green and fluorescein because each dye tells me something different. One focuses more on the lid margin and conjunctiva. And like Jen, I look at it with a cotton tip applicator. And the new ASCRS recommendation is push, pull, left, look, or in a different, left, look, push, pull. And those are really important. And after all of that is when we customize a specific treatment protocol. Christophe, do you use lissamine green dye, or Jen, do you, or Alice, do you? I'm curious.
Yes, I use it mainly for clinical trial. And lissamine green showed me that the conjunctiva is a very important part to examine. And in fact, to avoid to have too many dyes, I may use fluorescein in the conjunctiva. That is also very interesting. Physicians are educated to look only at the cornea, but the conjunctiva is a very interesting area where fluorescein is also useful. But effectively, sometimes when it's a mucin deficiency with no fluorescein staining, lissamine green may overcome this difficulty to address the question of conjunctiva. So effectively, it's a very interesting test.
Alice, would you like to comment whether you use lissamine green, or if you do, when do you use it?
I use lissamine green, especially during clinical trials. I don't use it on a routine basis. I feel like fluorescein kind of gives me what I need. I'm able to determine what the tear breakup time is with the staining, and then I can also assess the tear meniscus with that. I have it available if I want to use it, but I don't routinely.
And all of us, as we're describing our workup protocol, have alluded to time, how much more time it takes. So one of the reasons I have gotten comments from colleagues to not do dry eye is the amount of time it takes. So I'm curious to see how you have personally worked dry eye workup in your own clinics, in your hospital, Christophe, Jen, in your office, and in your office, Alice, to get the data you want out without extending that patient visit by too many minutes? So what are your secrets? Jen, we'll start with you.
Thank you, Cynthia. Well, you are right. It can start to really lead you down the rabbit hole of time when you get involved with these. And I think that's why, like we were discussing, we have streamlined really just listening to the patient. And I am doing the fluorescein and the exam, but I'm not doing every point of care diagnostic test out there because I'm seeing more general patients initially, you know, not in an academic center like Christophe. So I can pick up on the clues right away if someone has dry eye. And I think one pearl, I suppose, that I do to streamline is after I've made the diagnosis, I like to start the treatment step by step for the patients. I find that I used to really launch into the whole discussion about every possible treatment and theory behind dry eye, and that not only took a lot of time, but probably confused the patients a little bit and overwhelmed them. So I really stick to a brief description just to make sure I know they understand it. And then I start off with the initial treatment I want, and then ask them to return in several weeks for the next type of treatment. And I found that's worked better than, again, necessarily describing every possibility.
And we'll come back to treatments in a moment. Christophe and Alice, we'll go to you, Christophe. How were you able to do the diagnostic workups without adding too much time? Any secrets that you want to share with us?
I have not the great secret, but it's true that it's very time consuming. I would say that what I want to do myself is the slit lamp examination with the staining, because sometimes I can find some hints that have not been seen by the technician. So I try to delegate as much as possible, but at the end I want to have the examination. But before that, I consider that there is a part where I can be extremely useful. It's the first examination, the first consultation, and recording the history of the patient. It's like a police investigation in my feeling. And sometimes by the good question, you can identify the history. You can identify a whole history of allergy that could explain why 20 years after the patient progressively developed a problem. You can identify a whole history of systemic medication. You can identify rosacea just by looking at the face of the patient, and the patient didn't come to you by explaining, oh, I have rosacea and I am suffering from the eyelid. But you can observe that. So the first examination, the first series of questions seems to be a time that is very useful. Of course, it may take 5-10 minutes, so it seems to be long. However, those 10 minutes maybe will solve the problem and will avoid to have this kind of population of patients who are facing those patients or coming continuously, oh, I am suffering, or your treatment is failing, or I feel depressed and nothing works. So this first history is certainly one important part to avoid the following.
Yes. A comprehensive history is critically important, or a history of, let's say, herpes simplex, keratitis in the past, something like that. So Alice, we'll come to you and then we'll delve into treatments.
Yeah, so in a busy practice, dry eye patients represent both an opportunity and a challenge. So the opportunity is to provide better life-enhancing care, which is enticing. However, taking the time necessary to understand these patients, educate them on available treatment options and diagnose them can really put doctors and staff behind schedule. So we just recently, over the last couple of months, implemented a software system, MD Backline, that automates patient communication and history collection. And it's been a game changer for our practice, this dry eye procedure program, because it allows the intake process to be more efficient. our histories are more accurate, and our use of advanced therapies have been more widely accepted because patients are aware of these before they even come into the office. And then it also allows us a little bit more time to do the diagnostic testing and educate patients because most of the intake is already done.
And that's a very, very good hint that bi-directional communication with a patient ahead of time through a platform like MD Backline really helps, because the patients have the time in the comfort of their home without the rush of the office to answer all the questions they want. And then what we do is print the results, and it's available digitally incorporated into their EMR. So we have the answers to their responses, and this way we can start multiple steps ahead, saving that critically important 5, 7, 10 minutes. You're right. And I think there are additional platforms that are coming out to do just this. So now we've made the diagnosis, we have our testing, and now, Jen, I'm circling back to you. We're going to start treating the patient. You mentioned you didn't want to overwhelm the patient, and I completely agree with you, because an overwhelmed patient stops doing everything because they're so confused, they don't know where to start. So where do you start? And then I'm going to come to you, Alice, and then go to you, Christophe.
Well, thank you, Cynthia. Well, it depends, of course, where they are in their dry eye disease, how much other treatments they've had, and how advanced their actual disease is. But let's say, for example, it's a newly diagnosed mild dry eye patient who has never been on any type of treatment, including artificial tears. Well, of course, we've done our diagnostic exam. We've decided whether it's more evaporative or more aqueous deficient, or a combination of both. And depending what we find, so let's say it's more of a Meibomian gland disease process, I always actually will start now, of course, with lubrication, as well as warm compresses and possible cleansing solutions for the lids and lashes to get a baseline. This is something easy, of course, that patients can start with. It doesn't seem very intimidating. It's very cost effective for the patient. And this is how I begin the pattern. Now, of course, if they are feeling more exacerbated or more acute distress, I will often add a prescription medication, usually typically a corticosteroid to begin with if they are having acute symptoms. And then, so I'll start the basic lid hygiene and lubrication with artificial tears. Also, I like to talk about environmental factors, simple things. Again, I try to make it seem very basic and simple so they aren't overwhelmed thinking about lifelong prescriptions and expensive procedures. So I like to start simple, and then maybe even add a corticosteroid drop just to get them started. But I always talk about, like you mentioned, Cynthia, it's more of a chronic condition. We're treating you. Please don't expect this to get better in 2 days. And we really need to work together, make it a team approach. I like to set that groundwork, and then I have them come back in several weeks, of course, to appropriately follow their intraocular pressure to make, if I have put them on a corticosteroid, in order to follow them, and then to move them on to the next part of therapy, whether it be a procedural based ideas such as, thermal pulsation, or if it's going to be more of a prescription medication drop.
Right.
So let's take it step by step.
Jen, I think you said, A, not overwhelm the patient, and 2, set proper expectations that you're not going to get better in 2 days or 2 weeks. Right. So those are really important. Christophe, how do you start treatment? Because I know you have a different population of patients who are more advanced. They're coming to a tertiary academic hospital setting. So what is your approach?
Thank you. First, I totally agree with Jennifer. My approach is very similar. If I want to say the same a little bit differently, I would wish to emphasize on 2 ideas. The first one is effectively to collect all possible information about the previous treatment. Some patients, for example, come with preserved eye drops. If a patient is dry with eye drop and treating the dry with eye drops that contain preservatives, especially quaternary ammonium that are detergent for the tear film. So the more they feel dry, the more they put eye drops, the more they put preservative, the more they have dry. So the first step is to try to eliminate at least benzyl chloride. This is important because many patients are treated with OTC compound, and most of them contain preservative. So first, I try to identify the problem, eliminate what can be done. The second point is effectively to try to have an idea. Of course, it's too much schematic, what I will say, because there are plenty of overlap between the two pathologies. But some patients come with obviously a tear deficiency. And most tear deficiency, like in Sjogren, will be associated to corneal damage, corneal staining, keratitis, it's the same. So in that case, we know that it's highly inflammatory, and my approach will be, beside artificial tears, gels, or hyaluronic acid, I will try to use, or I will propose very quickly to use cyclosporine, pulse therapy with steroid, or a combination of both. On the other side, I see patients where it seems to me that the disease comes from the eyelid. It can be a rosacea, blepharitis, MGD, but the inflammation seems to be located mainly in the eyelid. In that case, what I will see at the level of the eye will be mostly not tear deficiency with corneal damage. It will be mostly tear instability. And in that case, I will focus more on the eyelid with lid hygiene. It can be a standard lid hygiene or sophisticated method to treat eyelids. We can discuss later on the different options. But I will try to focus more on the lid hygiene. And in case of severe cases, like rosacea, very important inflammation on the eyelid, I will use specific strategies to decrease inflammation with, for example, doxycycline or azithromycin that can be used for these options. So, but first, the history of those patients, and last point, sorry to be a little bit long, but also to try to address the preference of the patient. Some patients are more comfortable with viscous components with gel. They feel protected and they are rather happy with that. Some patients don't like those compounds. They feel those compounds too viscous, blurring vision, and too sticky, and they will prefer artificial tears that will be more liquid. So the preference of the patient is also an important point to consider.
And those are really important points. Christophe and Jen, I agree with both of you. Sorting out the artificial tears is really important because sometimes patients come to us using anti-allergy eye drops thinking that they are artificial tears, or products to get the red out, which may be vasoconstrictors, and thinking that those are artificial tears. So you have to sort it out and then you know, add on. And I always feel we're layering or stacking the treatments, each one becoming more complex with a mixture of in-office procedures and at-home remedies. So Alice, now I'm circling back to you. How do you start your treatment algorithm once you've made the diagnosis of dry eye disease and MGD?
Very similar to Christophe and Jen and what you've mentioned. You know, obviously we want to base treatment on the type and the severity of the disease that they have. We also want to make sure that they don't have any masquerades like intramembrane dystrophy or you know, HSV keratitis. My threshold for starting patients on an immunomodulator is very low because we know that most dry eye patients have some inflammation, especially if they have signs of aqueous deficiency. And then, you know, we know that Meibomian gland dysfunction is the most prominent form of dry eye disease. So it's important to treat this early before gland loss, you know, limits the effectiveness of the treatment. And, obviously there's several options now, which is pretty exciting to be able to offer to patients that have MGD. So we offer thermal pulsation treatment. There's also ILUX and IPL and tear care for those MGD patients. I also start patients on a re-esterified omega-3, which I think is very helpful for these patients. Lid hygiene, hot compresses. MG probing is also becoming more and more accepted too.
We have so many options available to us now. We're fortunate, and patients are fortunate actually, to be the beneficiaries of this. I too start my patients on a re-esterified oral omega-3, especially in the presence of Meibomian gland dysfunction, because if the glands are not working and it's clearly visible on their meibography that they have significant gland dropout, something to make up for the lipid that their glands are not making. So I let them know that they have to import their lipid because their factory has shut down. So I agree with that. How do you feel, Jen and Christophe, about oral omega supplements? Do you incorporate them into your algorithm? Is it something common in France? I'll start with you, Christophe.
Thank you very much. I love this question because I am aware of the DREAM study that was conducted in the US that unfortunately failed in showing any efficiency over placebo. So the conclusion was it doesn't work. I'm not sure it's so strong. In fact, there were also in the past other studies that showed that it could work, it could improve the patient. And I was the principal investigator a few years ago on a similar study, and we used biomarker, and we were able to show a significant decrease of the biomarker of inflammation compared to the placebo. But clinically, it was not so clear, which means that probably there is a discrepancy between the concept, it may decrease inflammation, improve the quality of the tears, and the way to measure the efficacy. So this is one point. I'm not sure we will have time to address the question about the clinical trial. That is very, very complex in a disease where pain is important and where the placebo effect is important too, and also the fact that a placebo is an artificial tear. So a placebo in a dry is never a placebo, but nevertheless, coming back to omega-3, at least in some patients it works. Maybe by a placebo effect, maybe by a real anti-inflammatory effect, maybe because omega-3 are able to regulate the quality of the tears and especially the lipid layer. So it may work. What my personal pragmatic opinion is that I can propose, especially in MGD patient, I propose if after 3 months it doesn't work, the patient doesn't feel any improvement, I propose to stop. There is no interest of spending a lot of money if it doesn't work. But if the patient is happy with that, I am happy too. Last point, maybe the explanation is not a yes or no response. Maybe it's not it never works or it works only by a placebo effect. Maybe it's the same as in AMD. There is a new emerging concept on omega-3 in AMD. The fact that not all patients are lacking omega-3. If they are not lacking omega-3, there is no interest of supplementing omega-3 in addition. So probably some patients lack omega-3 and may be improved by supplementation. Some patients are not lacking any omega-3 or have a normal lipid balance. In that case, it will not bring a major improvement.
And it is a very complex situation. And I know, Alice, you've done the response to the DREAM trial. Maybe if you can quickly do that, and then we want to go on to office-based treatments.
Yes, so the DREAM study, there's been a lot of controversy, like we said, and criticisms over the results and the conclusions of the study. And I could probably talk for another hour on this, but press releases were saying that omega-3s don't help dry eye disease. And there were some major flaws in the design of this paper, but despite this, the conclusions that omega-3 failed to yield beneficial results were highly misleading and I think a great disservice to our patients, especially considering that 61% of subjects in the omega-3 arm experienced significant improvement, which is a pretty impressive response in the dry eye world. But there just was not a statistically significant difference between the omega-3 and the olive oil groups.
That's exactly right. So the placebo was olive oil. Both arms improved, but there was no statistically significant difference between the two arms. So Jen, I'm going to come to you. What in-office procedures do you offer your dry eye patients, and where do you position in-office procedures? Do you do them the first time you meet and like the patient could be overwhelmed, or do you bring them back? How do you do it? And then I want to hear from all of our panelists about the role of in-office procedures.
Well, great question. Thank you for asking. So similar to my earlier discussion, it really depends on where the patient is in their treatment and level of dry eye, of course. But let's say for illustrative purposes, this is their first time they've been diagnosed. And I do notice that they have issues such as blepharitis and Meibomian gland disease. I do start with the home remedies, like I talked about, just to get them started. But at the same time, I will mention that when they return, I want to discuss in-office-based treatments that could be better. But again, I like to get them started at home just to get the concept going. And then I do offer a treatment called BlephX, which is microblepharoexfoliation of the lids and lashes. And I like to start off with that, of course, if I notice a lot of collarettes or blepharitis or scurf. I also perform procedures such as thermal pulsation, like LipiFlow, as well as tear care, which is the open eye experience of applying heat and then clinician-directed pressure of the glands in order to extract the oil. So both procedures do target the Meibomian gland specifically in order to treat the evaporative component. So I do like to present all the options to the patients. A lot of times I will encourage them doing BlephX and then one of the lid procedures, possibly in the same day. And I really, one reason I do like to start off with that home remedy of using treatments such as hypochlorous acid spray, and as well as home masks to wear for the warm compresses, because if patients come back noting an improvement, which they usually do tell me honestly that they have noticed improvement. I feel like then I have much more grounds to encourage them to undergo these procedures, because in the US, these procedures are still self-pay. So it does come at a cost to the patient. So I like to show them how we're starting off and improving them, and then explaining the concept of these procedures. So I am a big believer in the procedures. I've seen firsthand how they work, and I think it's a great value add to our patients.
And Alice, what in-office procedures do you do? I agree with all the things you said, Jen. I too bring the patients back once they're encouraged and like seeing some and feeling some improvement, and then start adding these different procedures. And it doesn't mean it's one procedure and done. It's actually many procedures are complementary to one another. What are your thoughts about that, Alice? And then we'll come to you, Christophe.
I completely agree. I think that, a lot of the treatments are complementary. So we actually have in-office procedure once a week. So we have dedicated days that we bring patients back. And typically I do a thermal pulsation treatment. I combine it with the BlephX treatment, and then I do an expression afterwards. And then I give patients a list of kind of instructions to kind of almost like a maintenance program, because I think that even if they tried hot compresses and an immunomodulator before and they didn't feel like it was helpful, I think all treatments tend to work better once those Meibomian glands are unobstructed and functioning. So I'll tell them to do blinking exercises, the hot compresses, use lid scrubs using hypochlorous acid, continue their omega-3s, you know, preservative-free artificial tears, maybe a gel at nighttime. And the overwhelming majority of patients that, you know, kind of remain on that program notice an improvement afterwards.
Exactly. And the key is to let the patients know that they have to maintain doing all these things. And by doing their heated masks at night and taking their oral omega-3s and using the proper artificial tears and doing their lid hygiene, whether with a handheld kind of oscillating device or lid wipes, potentiates and maintains the beneficial effects of the in-office treatment. Christophe, what do you do and what do you have access to in France in terms of in-office procedures?
We have almost all techniques except Blefex. I don't have the personal experience of Blefex, but we have two types of warming devices to press and to remove the Meibomian that is stuck into the glands. So I don't want to take the commercial names, but you can imagine those. And right now I am more focusing on the IPL, intense pulse therapy, light therapy, sorry. That seems to give interesting results. To be honest, I don't really, I may understand why after warming and massaging the eyelid, I can improve the dysfunction. I'm not absolutely sure, and I'm not sure that anybody somewhere is able to really understand the demonstration and the mechanism by which it works. But effectively, by acting on the vascular bed, maybe the lymphatics, and maybe inflammation, and maybe the microorganism locally in the eyelid and around the eyelid, seems to give more reliable results. This is my feeling. I'm not sure it works better or the same, but at least the same and maybe a little bit better.
I too, like you, Christophe, use the intense pulse light, and I am now looking to do a study of combining a series of intense pulse light with a thermal pulsation mechanism, because the mechanisms of action are different. One heats and evacuates, the other one treats inflammation and the periorbital, periocular lymphatics and vascular systems. So maybe this could be a group study that we can all do together. But we are so fortunate to have the tear care, the iLux, the IPL, the LipiFlow, the Blefex. These, if you look back 7, 8, 9 years ago, none of these were available to us. So patients and we as clinicians are so fortunate to be able to diagnose, treat, and actually deliver some help to our patients who are suffering so much. So any other pearls that you wish to add to this conversation that we didn't cover? Because we're coming to the top of the hour and we're going to open it up to our attendees. If you have any questions, we can start answering your questions.
I was going to say, Cynthia, while we're accumulating those questions, I would love to hear from the panel what you're most excited about technology-wise about dry eye disease, new technologies.
Many new technologies, of course, are coming down the pike. Some of them are pharmacological, meaning eye drops or pharmacological compounds that will help treat, let's say, Demodex, that's coming down the pike. We have a nasal spray that hopefully may help with tear stimulation and fighting inflammation. That's coming down the pike. We have different procedures that may have longer lasting effects to help with Meibomian gland health. So all of these are exciting things to try. How about you, Christophe, and you, Jen? What do you have that you're excited about?
if I can start long time ago, the first magic point I found when I was first treating, when I was a fellow and a young professor, the first magic tip was removing the preservative. I solved almost 50% of the problem of the patient. So I got the reputation of that I was very good in dry. I was just stopping a part of the treatment that was done by another ophthalmologist. So honestly, it was not so strong and so clever, but it worked. The second magic point was when cyclosporine came to us. So in Europe, in clinical trial, for me, it was at the end of the 90s. And I was facing patients in which nothing worked. Nothing was able to relieve them because they had tried many different tear substitute, quantum plugs, whatever. So when I started cyclosporine, I was able, approximately, but I'm not so far from the truth, I was able to really relieve 50% of the patient, to improve 25% of the patient. And I had a failure, or I was unable to really improve the patient in 25%. But starting from zero success, going to 50 to a little bit more than 50% of full success, and another 25% of improvement, it was magic for me. And I had also the same feeling when I discovered first that in severe eyelid involvement, I mean rosacea and so on, before the warming, before the devices that are quite interesting right now, doxycycline was able to really improve patients. So of course, not for all patients with just mild MGD. It was for severe patients because it's a systemic treatment. But I was able to really improve severely affected patients. So these are my three major points that to me were really an innovation in my practice.
Are these treatments covered in France, Christophe, or do patients have to pay cash for some of these procedures that you're referencing?
For the procedures, effectively the procedure, so mechanical procedures, it is not covered by the insurance. So they have to pay. So effectively, it may be an issue for some of them.
Because it's the same as Jennifer and Alice mentioned. These are also cash paying procedures in the United States. So Jen, what are you excited about?
Well, I think that, like Christophe was saying, I don't have a lot of personal experience with intense pulse light, but I think I was very interested to hear Christophe's perspective and your perspective as well, because I think there's a lot of growth in that area because, as we all mentioned, most of the dry eye, 86% at least, is coming from the problems of the lids. And I'm fascinated by how much telangiectasias I see on the lids, how much chronic inflammation I see on patients, especially those who are elderly. So besides the traditional IPL, I know there's a lot of new treatments coming out, in-office treatments. There's even one called EI that I had read about that's supposed to be similar to an IPL, but maybe a slightly easier point of care test. Again, I have no personal experience with it, but I've been hearing different technologies coming down the pipeline that can maybe make this type of intense pulse light therapy more available to our patients and to us as clinicians. So I think there is a lot of room for growth in that arena because we really have to get the lids healthier. I think that's where we're
And
lacking.
Alice, I'll come to you. What are you excited about that's coming down the pike?
A lot, but we're getting ready to start enrolling patients in the phase 3 study using Noveleak's product. It's a proprietary water-free, preservative-free solution that may help patients with Meibomian gland dysfunction. So we're excited to start that.
That's exciting. So we do have so many options, as we were saying, So our patients are fortunate, and the world is fortunate to have experts like the three of you to share your wealth of knowledge with our colleagues so that we can disseminate this to help down the road, help every patient who's suffering from dry eye disease. So with that, we're going to open it up now to our participants and our registrants to see what kinds of questions they have. And we're going to start with those questions. In the meantime, as the questions are coming in, Alice, Jen, and Christophe, when you see patients who are scheduled for a cataract consult, how do you work them out? Do you work them up for dry eye disease in addition to cataract evaluation? What do you do? Alice, I'll start with you.
Well, this is one of the reasons why I've become so passionate about treating dry eye disease, because we've come to realize how an unstable or an unhealthy tear film can really affect our surgical results. So it's critical that we look for and assess, evaluate any patients that are coming in for any ocular surgical procedure for dry eye disease in order to get the best results. So we use the MD backline. We obtain the history. We are able to get the speed questionnaire all ready before they come in. And, again, we do, point of care testing for these patients, especially those that are symptomatic. But I do get point of care testing for all of my cataract patients, because, there's some patients that are asymptomatic that may not have, that you may not express symptoms. So we want to screen those patients, and then just really, looking carefully at the slit lamp for, looking at their lids, their lashes, express those glands, looking for pre-existing conditions, I think is critical. So, and then, if you diagnose dry eye disease, then obviously you want to educate patients and treat them. We saw from, Billy Trattler's study, the PHACO study that he and colleagues did, how prevalent dry eye disease in patients that are presenting for cataract surgery. I think that the 87% of patients scheduled for cataract surgery had a level 2 dry eye or worse, but only 22% of those had a previous diagnosis. So that really kind of drives that point.
And that is so true. Each of my cataract consult patients back in the day when I was doing cataracts just a few months ago, what I also worked them up as a dry eye patients, following all the things that we talked about. Jen and Christophe, do you concurrently work up your cataract patients for dry eye?
Yes, 100%. I agree with Alice and what everyone has been saying. If you don't diagnose it prior, they're going to blame you after the surgery. And oftentimes the patients have already been diagnosed by myself or another doctor, but I definitely bring it up. I definitely start management. If I'm not happy with the scans ahead of time, I put a pause on the process, start treatment, and make them come back before we proceed with cataract surgery. So 100%, it's vital.
And how about you, Christophe?
Yes. Yes, absolutely. It's very, very important to identify those patients because if a patient comes from other reason and is asymptomatic, you diagnose MGD or eyelids crushed, and you can consider that it's not very important. But before cataract surgery, it's extremely important to identify those patients, even asymptomatic, because they may become strongly symptomatic after. They may complain of symptoms. All of us have patients who have told us, oh yes, since that surgery, I have this eye that is stinging a lot or burning a lot. And yeah, okay, you have dry. No, I don't have dry. Before the surgery, I have nothing. So it's very important from the symptomatic point of view, and very important also for the vision point of view, because especially if you consider using premium IOL, if the quality of the tears is not good at all, the result will be very poor. And if you have a cataract surgery that gives a mild or not a very good vision, the patient will complain of the visual aspect. So it's very important to identify those patients and at least to educate them, to treat them, and at least to inform them there is a risk that you may experience dry. Like in refractive surgery, it's classical to inform the patient that there is a risk of developing dry for at least in the first month. The problem is when it's more than six months that the patient is still complaining of dry. This is another story. But it's a similar aspect, not only in cataract for refractive surgery. Identification and education of the patient is very important.
And these are all such wise recommendations. So thank you, panel. One of the questions that I'm sure you have been asked, and I get asked this a lot, is where do I start? You guys are experts, you know all these things, but I've just been a comprehensive ophthalmologist and cataract surgeon. I don't know where to start. So Alice, where would you recommend a colleague to start if they have not been focused on dry eye?
So many ophthalmologists avoid, or eye care practitioners in general, avoid treating dry eye disease because they feel that it's going to slow them down. Some also believe that treating dry eye disease has a low profit margin. Some worry that it would distract from their surgical practice. But those are myths, they're not true. So creating a dry eye center of excellence, it involves a kind of a multi-dimensional approach. It's something that any practice can accomplish, and you don't even have to call it a dry eye center of excellence. It's just something that you can treat dry eye, dry eye patients. So it's a great practice builder, and focusing on dry eye disease treatment improves, like we have discussed in the last hour and a half, improves our biometry and IOL calculations prior to surgery, and most importantly, improves the patient's quality of life. So, of course, the goal is not only to help solve these problems, but to educate patients about the nature of the problem, which, definitely leads patients to be more compliant with their treatment. So I think if you're, thinking about, kind of focusing more on dry eye disease, you want to probably, maybe try to contact colleagues that have developed practices, dry eye, centers of excellence, so that you can, kind of learn from them. The other advantage of really focusing on dry eyes, we have the opportunity to participate in clinical trials and to have access to new cutting edge treatments and technologies that may not be available in private practices. So I think there's, lots of benefits.
Those are really wonderful responses, Alice. Thank you. Jen, what would you add to that, if anything? You were so comprehensive, Alice. That's so true.
I don't think there's a lot to add. I feel like I learned a lot just from listening to Alice.
And Christophe, if a colleague in France says, I don't know where to start, I'm not in a hospital setting, I don't have all the tools that you do, what would you recommend to him or to her?
I would say first to listen to the patient. It may take some time, but it doesn't cost anything and doesn't require any major investment. Listening to the patient, observing the patient, looking at the few hints that are available in the level of the slit lamp, at the level of the eyelid, the cornea, the conjunctiva, as we told. To me, it's important, even without sophisticated method, to remain clinician. I have done a lot of work in the past on imaging techniques. I just want to share my feeling, my experience. I have looked at thousands of images with OCT, with confocal microscopy. So I have a back and forth method from the patient to the technique, from the technique to the patient, which means that the best is that when you are familiar with the imaging technique, at some moment you don't need anymore the technique. You are able to recognize from clinical hints or few clues that there is something that is probably inflammatory, probably involving the nerves, probably related to the skin or to the eyelid, or related to a systemic disease. We can talk about neuropathic pain and fibromyalgia, Sjogren, and so on. So at some moment, you don't need anymore. So maybe as my role in educating my colleagues is probably to explain them what I got from the technology and what I can deduce without the technology, because I know with the technology what I can recognize without.
Yes, those are really good pieces of advice. Our questions are pouring in now, and I'm going to ask them to our panelists. If the glands are keratinized and the MGD orifices are clogged, how do you recommend best treating it? And a dovetail to that question is, how does BlephX work? So Jen, since you do BlephX, do you want to start with this question?
Sure. No, it's a fabulous question. I think that it is important to remove the keratinized or plugged part of the gland prior to performing an expression. If a patient is able to undergo BlephX, I highly recommend it. I think the BlephX or microblepharoexfoliation procedure in and of itself will help debride the lid margin and remove that keratinization. So that's a great option. If a patient's not able to undergo the extra procedure, then what you can do are, if you have a lid expression device, some of them on the end will have an area where you can debride, or you could take the forceps and just gently debride yourself manually the lid margin. So it doesn't take a lot of force or effort, but I think gently sweeping and just removing the extra keratin layer is extremely valuable.
And the way the BlephX works, it's a handheld device for those of you on the program who don't know how to use it. It has a disposable, replaceable tip that you dip into a hypochlorous type solution or anything else, and then you press the button, and it has a rotary system where that sponge soft tip rotates, and you go back and forth along the lid margin, the upper and lower lids, to kind of remove that biofilm, that scarf off the edge of the eyelid to open up the orifices of the glands. And it doesn't hurt. It takes but a few minutes, and all you need is a topical anesthetic to open the eye. So one other question, go ahead, Alex.
Let me make one comment. You know, one thing that I kind of explain to patients when I'm doing BlephX is that, you know, again, like you had mentioned, it's removing that biofilm that contributes to the clogging and the inflammation. But it's analogous to the plaque that builds up, you know, on our gums and our teeth that contributes to that chronic gingivitis and gum disease. So patients kind of tend to they realize how important it is to take care of their teeth. So I think that, you know, they can hopefully see how important it is to take care of their eyelids and their eyes.
And the analogy to the dentist model is great. It's the deep clean, whereas let's say the daily lid wipes or their topical immunomodulator would be like brushing and flossing. This would be the role of the hygienist in the office doing the deep clean. Another question that we have from our audience is, how often should MGD patients have Meibomian gland expression? How often do you bring them back, and do you mix and match treatments? Who would like to take this one? Well, I'll start. I can take it. You know, it depends on the severity of the patient's Meibomian gland dysfunction and the severity of their symptoms. What I love about dry eye disease is that there's no cookie cutter approach. Every case is different, and you have to basically come up with a tailored approach to fit that person's level of disease. So perhaps initially you start with making sure they're using the right tears, or an oral re-esterified omega, similar to all the things we mentioned, a heated moisture mask, because that maintains the viscosity of the meibum to be more liquid, so it doesn't solidify and clog the meibomian glands. And then there are different treatments. For example, many times I might do a thermal pulsation or a thermal heat and evacuation like iLux or tear care or LipiFlow, and then bring the patients back and pair it with an IPL and pair it with a BlephEx. So there is not one and done. It all depends on what you find and the symptom relief. Alice, what would you say to that?
Yeah, I completely agree with that philosophy. I actually have a patient that I bring in every 3 months to express, and I get quite a bit out, and she gets so much relief after doing that. So, you know, I think that you just have to take each case differently, and again, if they have signs of meibomian gland dysfunction, that's something that needs to be addressed.
Now, Jen, we have another question, and then we'll come to you, Christophe. Do you typically prescribe topical steroids or NSAIDs after any of these types of in-office procedures? And if yes, for how long?
Great question. I have not been prescribing a topical steroid after procedures such as BlephEx or thermal pulsation therapies, but I do often prescribe steroids after placing punctal plugs. Because I do think that when you place the plugs initially, there can be a little bit of discomfort. So I usually will tell the patients for 2 to 3 days to use a topical steroid. But I think that there is still value probably in doing a steroid after the other treatments we discussed, but I have not been having to do that.
Very good.
The same for me. I don't use steroid after IPL, for example, or after LipiFlow when I did it. However, the problem of inflammation before or after a punctum plug is very interesting, because some failure in punctum plugging are due to the fact that if you retain inflammatory tears, you will increase the level of inflammation in the eye, which means that associating punctum plug with an anti-inflammatory strategy is a very good option. And just one point about NSAID for the all people who are attending this webinar, it's to be very, very careful in using NSAID in case of corneal involvement, corneal epithelopathy. If there is a keratitis and significant corneal staining with NSAID, don't use them or stop them immediately, because corneal melting may occur, and I've seen several cases of corneal melting after NSAID. So be very careful. But especially autoimmune disease, Sjogren patient after surgery, where it's usual to use a non-steroidal agent. So be very careful. It can be extremely toxic.
Christophe, we have a question for you. That was a great response, all of you. How would you treat aqueous deficient dry eye disease, not MGD? And does IPL have a role in that?
In those cases, I don't see, but maybe it's too early to have a definitive answer about IPL, because maybe it could work, because secondary MGD may occur even in Sjogren patients. But aqueous deficiency, in my experience, is mostly Sjogren or Sjogren-like or autoimmune disease or systemic disease. So in those cases, in my experience, cyclosporine is a good option.
And Jen or Alice, if somebody has aqueous deficient dry eye disease, which represents a smaller percentage of our patients, often it's mixed, right? It's hard to say it's just one or the other. Often it's like a continuum, a blend, unless of course they have been diagnosed with Sjogren's or have systemic documented disease. do you treat these patients differently, and if so, how?
Jen, do you want to take that one?
Oh, sure. Thanks, Alice. Yes, well, I agree with you, Cynthia. I mean, we do have to identify the different etiologies, and I will lean more towards topical prescription medications, such as cyclosporin and lifitegrast when I believe it's more of an aqueous deficient. So sometimes I'll start more with that in the beginning, or a topical steroid as well. You know, when that then necessarily jumping to the lid therapies. And of course, artificial tears and the other things we discussed as well.
Very good.
I was going to say, I do the same thing. I mean, I use either cyclosporin or lifitegrast just to kind of calm down the inflammation, which hopefully will help to increase tear production, which is the indication. And then also I'll start them on a Reasterify omega-3 too. So
That's great.
Sometimes I'll start a steroid, you know, if they're surgical patients, because that helps to kind of get them better a little quicker too. And then I'll also use a steroid after do Blufax and LipiFlow too.
That's great. We have time, I think, for one more question, and this has to do with patients with rosacea, with MGD. And the question is, how often do they have IPL treatments? How many series does one do? How many weeks apart are they scheduled? So Christophe, I'll ask you this one, then I'll jump in, and that will be the last question we have time for.
Very shortly, you summarized very well the answer, tailoring to the patient. If the patient is severe, maybe I can have every month at the beginning an IPL therapy, and if it seems to be more efficient or less severe, 3 months we reevaluate, and maybe we do that again. So depending on the severity of the patient, very clearly.
Very good. Well, thank you, Alice, Christophe, Jen, you were fantastic. I am so fortunate to have experts like you on this panel. And thank you again to the ophthalmologist for putting this incredible program on.